All right. Welcome, everyone, and thank you so much for joining us today. We are really excited to be here with all of you today. We are going to spend the next hour diving into how PCAs and HCCNs drive innovation and scale best practices, particularly when it comes to childhood chronic disease and how they support health centers in doing this work. And so with that, let's go ahead and get started. A couple of quick housekeeping notes before we jump into things. You will notice that everyone is muted, but we do encourage you to please use the Q&A feature to submit questions throughout the session, and we will have time for Q&A at the end. This session is being recorded, and the materials will be emailed out to you afterwards, including a PDF of the slide deck. You'll also notice that you will be redirected at the end to fill out a brief evaluation, and we would love to get your feedback, so please take just a couple of moments to fill that out for us. It really helps us understand what you liked and what we can do better for future sessions. Today's session is being hosted by two members of what is called the Connected Communities Health Initiative, also known as CCHI. CCHI is a group of national training and technical assistance partners who work directly with health centers to improve the health and well-being of patients and communities. Our focus is on practical tools, real resources, and learning opportunities that help providers tackle root causes, not just symptoms, and create lasting positive change. That framing is really central to everything that we're doing in this series, and so I wanted to ground us there before we get into today's content.
Hello, everyone. My name is Karnisha. I am one of your facilitators today. Myself, along with Sydney with NAC, are super excited to have you here. I am a program director with MHP Salud, and Sydney is with NAC. Next slide, please. All right. About MHP Salud, we have been around for over 40 years doing the good work of working within our various communities and such. And we believe that supporting community health workers is the way to go. We believe that we train and work with health centers. We were based out of South Texas, but now we're located in a variety of different states. We continue to serve farm workers and community members as through all walks of life. And we believe that doing this good work is the best way to be.
Thanks, Karanisha. And just a bit about NAC for those of you who may not be familiar. NAC is the National Association of Community Health Centers, and we serve as a national voice for health centers. At our core, we exist to support health centers in delivering affordable, effective, comprehensive primary care that is community-driven and improves health for all. For today's conversation, we also want to note that we work closely with primary care associations and health center controlled networks. PCAs and HCCNs are not peripheral to our work. They are central, and we would not be able to do our work without them. We are very grateful for all of our PCA and HCCN partners. So why this series and why now? This webinar series has three core goals. First, we want to increase awareness of childhood chronic disease trends, what we're seeing among young health center patients and their families, and why this should be on our radar. Second, we are connecting those trends to the findings of the MAHA Children's Health Report released by the White House in May 2025. That report named key drivers of the childhood chronic disease crisis. And third, we are bridging all of that to the practical work happening on the ground, community health management, quality improvement, and integrated care initiatives. The point of this series is to move from awareness into action. And so that's the thread that you'll see running through every session. And it's especially true today as we talk about infrastructure, the PCAs and HCCNs that make action possible at scale. One quick note on what's ahead. So there is one final session after this in the series, and it will focus on using data and dashboards to move from insight to action. We will share at the end of the webinar the link to register for that, and we encourage everybody to register if you are available. So what we're aiming to accomplish together today. By the end of this session, we want you to be able to do two things. First is clearly explain the distinct roles and complementary strengths of PCAs and HCCNs, what each of them brings to the table, where they overlap, and why both are essential for driving change at the health center level. Second, we want you to walk away with practical strategies for improving pediatric chronic care that you can actually apply. So whether you are joining us from a PCA and HCCN or a health center. Our speakers today are going to make these ideas concrete, and so you won't just be leaving with a framework, but with actionable things that you can do. And with that, I will hand things back to Kyranisha.
Thank you, Sydney. All right, so in setting the stage, pediatric chronic conditions like asthma, obesity, diabetes, and behavioral health issues are increasing, especially in health center populations. So these children are often facing overlapping risk, including poverty, food insecurity, environmental exposures, and limited access to specialists. And so primary care plays a key role in prevention and early intervention. So health centers are well positioned to respond as trusted, community-based providers offering integrated whole person directed care. Next slide, please. So when we talk about primary care physician associations, or PCAs, those are our nonprofit organizations that support community health centers through training and technical assistance. They also serve as a state level voice advocating for legislators, Medicaid, and policymakers. These health center control networks, or HCCNs as we say them, bring health centers together to share technology, data, and expertise. They provide support in health IT, data analytics, and quality improvement. HCCNs help centers reduce costs, improve performance, and transition to value-based care. They also promote collaboration through training, peer learning, and share resources to strengthen sustainability and growth. Now, there may be several of you on here like, we know what PCAs and HCCNs are, but if we have some new friends, we wanted to make sure that they were aware as well of the good work that they do as well. Next slide, please. All right. So in continuing with that, there's no single health center that can address pediatric chronic disease alone. It takes shared infrastructure and collaboration. PCAs help connect centers through strategy, peer networks, and state level alignment, whereas HCCNs provide the technical support like data systems, dashboards, and quality improvement tools. Together, they enable health centers to move from recognizing problems to achieving real, lasting improvements for children and families. With that being said, we would like to introduce our wonderful speakers for today. Up first, we have Dr. Sandy Kaye. Dr. Sandy Kaye is a board-certified pediatrician and healthcare technology leader specializing in clinical care, medical leadership, and epic optimization. With over 15 years of experience practicing pediatrics, she brings deep clinical expertise to both patient care and health system innovation. As an epic physician champion at Health Choice Network, she guides clinicians and executives in effective epic implementation and workflow design, driving strong engagement and improvement clinical outcomes through data-informed system optimization. She previously served as a medical director of pediatrics at Miami Beach Community Health Center, where she established clinical standards, supervised providers, maintained regulatory compliance, and supported patient grievance processes. Throughout her career, she has provided comprehensive pediatric care while teaching and supervising medical students and residents. She currently sees patients part-time in Miami Beach, maintaining direct clinical engagement alongside her leadership and technology initiatives. Whoop, whoop, Dr. Kaye. All right. Up next, we have Sam Fisher. Sam Fisher serves as the Director of Patient Services and Engagement at the Michigan Primary Care Association, MPCA, where she oversees the value-based care community health worker and accountability care organization care management programs. With over 9 years of dedicated service with federally qualified health centers in both Illinois and Michigan, Sam brings a depth of experience, skill to her work, and improving patient outcomes through innovative care models and collaboration. Her background includes enabling services, health center operations, quality improvement, risk and compliance, and electronic health record (EHR) administration. Sam received her BS in healthcare administration from Alma College. She is passionate about empowering frontline care teams, building sustainable community partnerships, and fostering system levels changes to improve the delivery of primary care services across Michigan. Let's give it up for both Dr. Kaye and Sam. Take it away, ladies.
Thank you so much. Such a pleasure to be with you all here this afternoon. Next slide. All right. So as it was mentioned, we're here to describe how HCCNs address childhood chronic disease through data analytics, interoperability support, and quality improvement initiatives. We're seeing a significant rise in pediatric chronic conditions, particularly obesity, asthma, type 2 diabetes, and behavioral health comorbidities. From a provider perspective, the challenge isn't just the condition itself, it's the environment, right? We have limited time visit times, we have increased documentation burdens, we have fragmented data across multiple systems where pediatric patients receive care, and there's difficulty tracking patients over time. We tend to have a transient population with that moves around frequently, so it's hard to track them. So this creates a gap between what we know and what we can realistically do in a busy clinic setting. So the question then becomes, how do we bridge this gap? Next slide. Okay. So what is the role of HCCNs in this process? This is where we play a critical role because we provide the infrastructure that individual clinics typically cannot build alone. We provide a basis where we can aggregate data across multiple health centers within our network. We can identify high-risk pediatric populations. We can benchmark performance across multiple clinic sites, and we support rapid cycle quality improvement for our health centers. So in simple terms, HCCNs can turn data into an actionable insight at a larger scale for our health centers. Next slide. So who is Health Choice Network? We're a health center controlled network founded in 1994 when a small group of community health centers within Florida recognized that they were stronger together, so they built a network. Since then, we have led a successful nationwide collaboration among health centers and our partners. We have a presence in over 20 sites and territories, including Puerto Rico and Hawaii. Together, we have over 12 million total patient visits a year. And we have over 94 safety net provider organizations. And within our network, we provide our health centers with key business services such as finance, managed care, billing support, strategic initiatives, health information technologies, clinical quality, and clinician training and development. Next slide. Okay, so within Epic, we have registries and reporting tools that operationalize this data. Providers and care teams can track chronic disease populations. We can identify missed follow-ups or any care gaps within our patients, and we prepare for visits ahead of time through pre-visit planning and outreach. So these shifts create from a reactive to a proactive type of care environment that supports pre-visit planning and outreach for our patients. Next slide. So in this, within our HCCN analytics, we can move beyond just an individual encounter and look at whole populations. So for example, we can identify children with a BMI of greater than 95 percentile who may have missed their follow-up appointments, or even take a look at asthma patients with frequent ER utilization. So this allows us to stratify risk, not just by diagnosis, but also by utilization and other health-related issues. This creates a more targeted, proactive type of approach of care for our patients. We cannot address pediatric chronic diseases without addressing other health-related issues. So these key factors such as food insecurity, housing instability, and transportation barriers that affect so many of our patients, this would allow us to identify these trends across populations. And while Epic enables us the tools needed for screening, documentation, referral tracking, it leads to a more holistic patient centered approach. So as you can see here, I've just included a screenshot of our typical spotlight of where during intake and questionnaires that parents would fill out, describing any specific resource strain, food insecurity, those would flag for providers and staff as red for them to clearly note that there was a risk identified, and they can further intervene and recommend appropriate community resources based on these screeners. Next slide. So within Epic, we have capabilities such as Slicer Dicer that allows providers to ask real-time clinical questions without needing an IT support. So for example, if I wanted to take a deep dive in my patient panel and which patients with obesity have received a nutrition referral, or which asthma patients are lacking an action plan, I can do that within the Slicer Dicer analytics and capabilities within Epic. And at the same time, we have what we call OPAs. These are called Our Practice Advisory within Epic, and they provide point of care prompts for providers. So they can trigger specific referrals, flag gaps in care. So for example, we have one for when a patient fills out a PHQ-9 or a PHQ-A depression questionnaire, right? And if they specifically on question number 9 that screens for suicidal thoughts, it's a yes or a positive. We have an OPA that will shoot and fire for our BH providers to prompt them to complete the CSSRS to further assess for risk of suicidal ideations. And if that results in itself, that screener is moderate or high risk, it will then fire a second OPA, will prompt providers to do a Stanley Brown safety plan for the patient. So again, these OPAs are used as prompts that kind of help standardize evidence-based care for our patients and relieve that cognitive burden for our providers from thinking what's the next step and what's the next, and kind of prompts them to do it. Next slide. This is an example of our current OPAs and what we have and different warnings that we have for our clinical support staff. So for example, the bottom right, you have a warning that will fire for our clinical support staff if they should be taking a vital and they see that it's alarming them and say, hey, this blood pressure is a warning, this is above the limit for this patient. Do you want to keep it, or do you want to retake it or go back? And should the clinical support staff keep it, then what you'll see above is that the vital signs will flag as red for the patient. So the providers and the clinical support staff can see that this was an elevated and abnormal finding for this patient. And we've incorporated the age percentiles for the blood pressure based on the 3 factors, their sex, their age, and their height. It'll flag if it's a positive and abnormal for that patient. And what happened is you will see that if there have been 3 separate occasions where in this patient has been seen and the blood pressure has been elevated, that Our Practice Advisory, or OPA, which is what you see in that yellow box that fires, that says, hey, this patient has had on 3 separate occasions an elevated blood pressure, and it prompts the provider to act on it and say, do you want a referral? Do you want to act on this, monitor, or do any further workup? So these are those type of guidance that we offer for our providers to make sure that they are using the best standards of care. Next slide. We also incorporate things such as smart sets and express lanes that further streamline care for our providers. So for example, for pediatric obesity or asthma, we have these, basically it's a straightforward A to Z where it includes the notes, it can include labs, referrals, patient education, everything that is pre-configured so that providers don't have to remember every single step, and allows for more efficiency, for documentation quality, and most of all, consistency across providers for these straightforward visits. I'll show you in the next slide. So this is a slide of what it looks like. So we have it'll prompt providers or clinical support staff that there's an express lane available based on the reason for visit that triggers it, or when they book their appointment. And if this patient was a asthma follow-up or whatnot, it'll trigger, you have an express lane for it to use. And as you can see on the right, this is basically, we have guidelines associated with as a reference where providers can click the smart link blue and be taken to those guidelines. And it basically offers the most common diagnoses, the most common labs associated with these diagnoses, imagings, referrals, level of service coding, and patient instructions. And also we've included medications as well. So you can find the most commonly medications ordered for this diagnosis where providers can utilize and click on. Next slide. So this is where the real impact happens, right? The integration of a health center controlled network and Epic. I think of it as a full workflow, right? We identify the risk through our HCCN analytics, then we act through Epic tools at the point of care and track outcomes through dashboards. So by identifying, we're identifying patients, we're enabling coordinated data-driven care, we're scaling at best practices across the entire network, multiple centers. We're using registries for pre-visit planning and care coordination. We leverage smart sets and express lanes, such Epic tools that would be of greater good and help the proficiency of providers be more efficient and get through visits quicker. We enable such guidance, such as our practice advisories, to help prompt providers on evidence-based care. And most of all, we engage patients through MyChart so that there is a level of communication between their care team and the patient. So this basically creates a continuous cycle of improvement and allows best practices to scale across the network at its entirety. Next slide. So what can providers can do tomorrow? So by utilizing this, we're using the registries, the pre-visit planning. They're leveraging tools such as express lanes, enabling OPAs for better guidance. So providers can use these registries, be more efficient, engage patients through MyChart. And these are immediate actionable steps that can improve care without adding to the burden of our providers. Next slide. The innovation opportunities looking ahead is AI-enabled documentation that definitely reduces burden for providers, predictive analytics to identify risk early, and incorporating tools such as Epic Cosmos to leverage broader data at an entirety for those, I would say, rare disorders or complex patients that you're wondering what's the best care and evidence-based care for this patient. You can utilize Epic Cosmos to see it at a greater good, not just within your network, but across the world, everybody utilizing Epic. It's patient data that is non-identifiable, but you can look and see in best practices and interact with other providers from other parts of the world. So this represents the next phase of transforming care delivery, honestly. Next slide. So the key takeaways here: childhood chronic disease requires a longitudinal data-driven care. Providers can't do this alone, so HCCNs provide the scale for them. And Epic enables the action at the point of care by utilizing Epic tools, dashboards, to be able to monitor and make sure that the care is there. So together, we improve outcomes, increase efficiency, and reduce provider burden. Next slide. So again, HCCNs evaluate the role you play in delivering data analytics, interoperability support, and quality improvement is what we try to evaluate and provide for our health centers. Most important things that HCCNs need to do is listen to their health center, the feedback that they provide, and continuously evaluate how HCCNs can better serve their health center needs. As for FQHCs, we need to understand what services your HCCN offers you and ensure that you're leveraging all of them and making use out of all the services they offer. Give feedback on gaps you identify and see what they can do to address them. So you don't need to do this and overhaul your whole workflow overnight. It's just small data-driven changes that are supported by the right infrastructure that can create meaningful improvements in pediatric outcomes across your network. Next slide. Thank you. You can follow us on HCN and connect with us.
Well, what a presentation to follow. In an effort not to say ditto or same across the board for what our HCCN is also doing, we are coming from the approach of how our PCA may differ from maybe the HCCN in your state or how we support our health centers across our state. So next slide, please, Sydney. So the Michigan Primary Care Association supports 40 FQHCs, 3 lookalikes, and 3 Native American tribal health service providers and 1 urban Indian health program, ultimately serving 1 in 14 Michiganders across our rural and urban communities. So we have a far spread across the state. We champion for health policy, foster collaboration, and support high quality, cost effective, patient directed care, which we'll talk about how our HCCN and our clinically integrated network support that as well. So we are unique to some other states and to HCN as well in how we operate both not only the MPCA, or the Primary Care Association, but also our controlled network, or MQIN, so our Health Center Controlled Network, which is our HCCN, our clinically integrated network, Michigan Community Health Network, and then Virtue Ally, which is a healthcare IT solution provider. We are all one team and are the same staff, similarly across all 3 of those different networks or different organizations. And so we are able to leverage that factor in providing support across the board and ensuring that all of our value-based agreements, technology innovations, and what we're championing at a policy level align with each other. Next slide, please. So our Health Center Controlled Network, or MQIN, was established in 2012 and is responsible for providing support to 41 of our health centers. Through our HCCN, our network members receive training and technical assistance from our staff and consultants to improve performance, optimize their resources, and leverage influence to create a supportive environment for their health centers. Next slide, please. And then our clinically integrated network was formed in 2015 and is currently owned by 40 of our 42 FQHCs and the PCA, and was created for the primary purpose of enabling our value-based agreement negotiation, engaging in focused performance improvement, and investing in shared services and infrastructure. So currently through our SIN, we have 8 Medicaid managed care value-based agreements, 2 Medicare Advantage agreements, and 1 Medicare ACO. So through all of this, again, in an effort to not repeat a lot of what Dr. Kaye spoke to about how our HCCN can support our health centers, we unfortunately do not currently have a statewide or an HCCN-wide EHR, although we are in the process of partnering with Dr. Kaye and her team to implement Epic across our state and their version of Epic. So we will be closely partnered in implementing some cohorts here soon. We're very excited about that. But ultimately, we currently have 10 EHRs that are utilized by our health centers across the state with varying degrees of support and varying degrees of technology that is able to be supported by those EHRs. So we optimize Azara Drives, which is a population health tool, in addition to some of their other modules, to be able to pull in data from all of our EHRs across the state and then provide that information back to the health center. So they're able to Dr. Kaye's point, see pre-visit planning, registries, slice and dice, look at their risk algorithm and see where their patients fall within those risk registries, and really use that to optimize how they approach care within their health centers based on their population and prevalence of chronic conditions. So we're able to support our health centers and our providers or clinicians in providing the best care for their patients by being able to leverage these technology tools. I do have some resources that I think Karanisha or Sydney will be dropping in the chat as well, in an effort to not have my slides just be the same screenshots, but maybe not Epic, but Azara that Dr. Kaye already shared. But ultimately, our goal here is to align all 3 of our organizations to have the same goal for our health centers. So we have our clinically integrated network that partners with our Medicaid and Medicare health plans, really optimizing some of those factors and chronic conditions and goals that are then optimized in our HCCN by supporting technology to support our health centers in better taking advantage of those goals and making sure that we're providing care to our health centers. So an example of that is high ED utilizers. So recently we did a deep dive into our ED utilization and really looked at age groups, what days and times were our patients utilizing the ED, where were they going, what diagnoses or what conditions were they going for, and how could we better bring them in for preventative care. And so in doing that, we realized that a lot of our patients and a lot of our pediatric population were going in for things that could be addressed during that well child visit and then better supported within our health centers for preventative care. So we did a deep dive into well child visits and really targeted our health centers that were below the 25th percentile for national Medicaid with their well child visit rates, 0 to 30 months. And 14 of those health centers created an action plan with our clinical performance consultants on our clinically integrated network staff. 8 of those health centers improved by 5% or more within a year. And we were able to leverage those well child visits to Dr. Kaye's point to support our providers in really identifying who may be at high risk, bring in other integrated care team members to support non-medical factors impacting health screenings, and see if there were other barriers that were decreasing the patient's ability to come in for preventative care, or to, if they were diagnosed with obesity, did they have access to fresh and healthy food at home, or did they need additional resources? So we try to come at it from a very comprehensive viewpoint about how can we leverage not only our HCCN, but our PCA and our clinically integrated network to have a combined comprehensive support for our health centers, so that when we are implementing these new innovative technologies, or workforce and apprenticeship programs, or TA and training, how are we making sure that we're all working towards that same ultimate goal of decreasing chronic conditions in our pediatric populations and our overall populations, and ensuring that our health centers are able to, really utilize their teams to the top of their scope and the top of their licenses, and not have to worry about finding the right technology partner, or really digging into that data and surfacing that information for themselves. We have access to that. So it is our role to go in and leverage that on their behalf, so that they can utilize those outcomes and those resources to implement workflows and really identify how they can better support their patients and communities. So I will pause there, because I know we have some questions that are coming in, and we have, I think, some things that we want to chat through on a deeper level. And thank you, Karanisha, for sharing those resources in the chat.
Great. Thank you so much, Dr. Kaye. Thank you, Sam. Yes, we do have a number of questions that have come in. And I know, Dr. Kaye, you've been able to answer a couple of those in the chat. So I would love to just kick off with more of a kind of a level setting question of, and this is for both of you, how do PCAs and HCCNs, how are you all able to complement each other in addressing childhood chronic disease? And then on the flip side, where do you maybe see the biggest opportunities for stronger alignment? So is there anything that's not happening right now that you think would really be beneficial to align on?
I can take the first part of it. So from an HCCN perspective, our role is strategy and making sure that we are able to make it actionable at a larger scale within our network. So we try to provide the data infrastructure, try to provide the electronic healthcare workflows and implementation support to bring all those strategies for our health centers. So I think that the biggest opportunity would be an early alignment and partnership between PCAs and HCCNs, because we both have the same initiatives, right? So that way we can offer our clinical guidance, help our centers with workflows and data tracking and all that. It's built together from the beginning to drive more consistency and greater impact for our health centers.
Yeah, absolutely. And I think from the PCA perspective too, our role is really championing policy and having TA assistance and workforce. We in Michigan have our Health Centers Career Training Program, where we assist health centers in supplying or curating apprenticeship programs. So we all have challenges with staffing, medical assistants, community health workers, nurses, dental. There are challenges in all of those realms to get staff in the door. And so how do we do some homegrown training and technical assistance to get staff in that can assist in that larger care team? And so then how do we then utilize those services to partner with the larger strategic technical innovations and initiatives that the HCCN has available, to then put those things together so that we can see, okay, where is the benefit to focus our TA or to focus our workforce assistance from a PCA perspective? And then how do we go ahead and have that all focused around the same goals ultimately across the board? I think to Dr. Kaye's point, partnering early on to figure out where those strategic alignments overlap and where we can best assist each other, and making sure that we're going about that support in the same way, or in the same, at least with the same end goal, so that we're working alongside each other rather than trying to take the health center's attention at different points, is far more beneficial than trying to achieve that individually, because we can be far more impactful together than we can independently.
That's really great. Thank you both so much. We have a bit of a kind of just a yes/no question. Do you all integrate with ECW? What does that look like, and how does integration work with different EHRs?
Sure. I
You
can,
can
Dr.
take
I
that.
different
Well,
response.
I
So
mean,
I don't,
yeah,
go ahead. Yeah.
I mean, with regards to, we have one instance of Epic, so it's one system that we share amongst health centers. So we are definitely able to, based on feedback of the health centers and what their needs are, we're able to utilize that, and we have different governance committees with regards to the clinical advisory for the medical, dental, behavioral health, to try to establish best practices. And since we share this one instance of Epic, it's more of a collaboration around everybody to make sure that it meets everybody's needs. But we also can cater to the service level, our individual clinics, and any specific needs that they want. We can definitely build it at their level. But it is, I guess, because it's one instance of Epic, it's great because I've seen patients where I've seen them within Miami Beach, and then I've seen when they've left Miami and gone to a different area, and I've seen notes from one of our network health centers, and it allows for better coordinated care, I think, utilizing this one system.
Yeah, we're definitely in a little bit of a different space here in Michigan. We do have those 10 different EHRs and do have a substantial number of our centers on ECW. And so Azara drives the population tool that we've leveraged to try to pull in data from all of those different instances, does partner with ECW and allow for that integration. So as you document, as long as you've done all of your data validation and mapping opportunities and things like that, identified where and how you want to pull that data into the tool, it will surface that within Azara, and it does allow for your peers to see how you're performing compared to how they're performing, which allows for a lot of that peer connection and support to naturally happen, where if you see another health center is performing, perhaps far better in well child visits or immunizations or lead testing, things like that, then it allows for that questioning and reaching out to figure out what best practices they've implemented and strategized on, to surface that across all of our health centers in the network.
Great, thank you both for sharing. Our next question comes in from our Q&A, which is, how do you find out what services HCCN, it says MO, which I'm thinking they mean Missouri, offers. I can say that NAC would be happy to connect you with state-specific organizations or even regional organizations that can support you. But this did make me think of a bit of a follow-up question for Sam and Dr. Kaye, which is, how do you let health centers know about the resources and services that are available to them? What does that kind of information sharing or communication look like for people who might not be taking full advantage of the services that you all offer?
With regards to information sharing, yes, we have a large social media following, make ourselves known as far as what we offer for our health centers. With any new upgrade within Epic, any new tool, we definitely, again, we have governance features within our network, and we have weekly spotlight health centers that are performing great and hitting their quality metrics and specific benchmarks. We try to spotlight those health centers to show best practices and share. That's the greater good of the network, right? Share those practices so the rest of the network can copy and utilize those and learn from that to try to be the best that they can at those metrics. We offer provider trainings. We try to embed ourselves in provider meetings within our health centers so that they know us, who the provider champions are, so that we can offer, and leadership would identify any provider needing help or whatnot, so that we can do one-on-ones to try to show them. And our goal is to avoid provider burnout. So try to teach them how to be as efficient as possible within the health system. Thank you.
Yeah, very similar for us. We are very intentional about reaching out to all of our different health centers across the state that we know are either newer or perhaps not yet members of our organizations, and are very intentional about communicating and interacting with centers that are members currently. So we have a plethora of different communication areas. So we have a system called Higher Logic, where health centers can interact with each other, post questions. I know NAC just released Higher Logic as well. So if you've utilized any of their communities, then you have seen kind of how it looks for us internally as well. But we post resources there, have open conversation with our health centers. They have open conversations with each other. We have annual meetings with our Health Center Control Network champions from each health center where they're able to spotlight the different innovative works that they're working through. We're able to talk through our goals for the year, interact with them. We have a variety of different monthly calls. We have support calls for all of our different EHRs. We have support calls for Azara Drives and Azara Care Connect. And so we just try to open up as many communication methodologies as we can to ensure that health centers are feeling supported and know what's coming down next. We have newsletters, things like that. So very similar to what HCN is doing, but just trying to push out as much as possible what's out there for the health centers to take advantage of, because it's really all for them and we want them to utilize everything that makes the most sense for their health centers workflows and initiatives.
Yeah, it really sounds like both of you are kind of taking a multifaceted, like all angles approach to getting the word out. And I'm certain that, your providers and your health centers are really appreciative of that there's different ways to get engaged. With that being said, it's one thing to establish a program, it's another thing to be able to scale up a program. So what are some of the strategies that you all have used when it comes to successfully spreading best practices across health centers or across regions?
For us, it's training as much as possible, right? Because that's I think that's the most effective way to make sure that the workforce capacity improves their training, technology, and that the workflows are all aligned. That's essential. So we embed clinical guidelines directly into our EHR, specifically Epic, to optimize those workflows, reduce documentation burden, reduce provider burnout, and continually provide ongoing performance feedback for our health centers to make sure that they're doing well. But again, the key I would say is training, continuous training.
Yeah, I would agree with that. Because we have the 3 different entities all together, we do partner with the Clinically Integrated Network and the Health Center Controlled Network together. We have a clinical performance consultant from the Clinically Integrated Network side and a data analyst from our HCCN side that meet either monthly or quarterly, depending on how the health center is performing or what needs they have. And they go through action plans, or what different measures are we having complications with, what training opportunities are there, because we do have so many different instances of different EHRs. We try to meet each health center where they're at and what their workflows are looking like. But agreed, it's a lot of training, a lot of interaction, a lot of coaching. It seems like the one-on-one meetings with all of our health centers to see where they're at and what their specific needs are and how we can tailor these larger strategies to their specific health centers seems to be the best approach. So while we may have, like I shared in the resources, some clinical pathways or some action plans, we then try to meet with each health center to see how that can best be implemented within their workflow with their staffing model to make it successful for them. So a lot of one-on-one coaching and interactions to help support a lot of those trainings.
And as a follow-up to that, what are you all doing to help ensure sustained improvements? What are some of the things you all focus on when you think about like sustainability of what you're offering?
With regards to sustainability, again, it's that constant interaction with our health centers, knowing, having those one-on-ones with leaderships, seeing what we can provide them to make sure that they can obtain the most funding through their quality metrics, and making sure that they're as successful as possible. Because when the health center is successful, I think we as a HCCN and as a network are successful ourselves, to making sure that they're not alone and providing that continuous guidance. And again, through data, we use a lot of real-time data to reinforce the guidelines, to reinforce provider trainings and everything, to make sure that our centers are up to par, and we try to make ourselves available, providing that one-on-one support to them.
Yeah, agreed. We really try to make sure that what we are implementing can sustain beyond any initial funding that may be supporting that original, staffing model or technology implementation. So how are we aligning that with perhaps a value-based agreement and a measure in there that could perform and increases the health center shared saving opportunities so that they continue to have that funding available, perhaps outside of either a one-time funding opportunity or grants to continue to sustain that model and to see that improvement move further. So a lot of that aligned, again, focus and integration and really ensuring that what we are implementing meets the health center where they're at. So not trying to, implement a workflow that maybe works at our health center that's seeing, 30,000 patients a year at a health center that is seeing 5,000 patients a year, because their staffing models are very different. Their approach to care may be different if they're rural versus urban. So how do we make sure that that best practice that we're scaling across the state is really intentional for that individual health center and their patient population as well? So making sure that however we're doing that PDSA cycle or implementing those workflows, is not only aligned with evidence-based guidelines and best practices, but also is aligning with that staffing model and that opportunity that's in that community.
When it comes to kind of utilizing some of this data and analytics, specifically to improve care for children with chronic conditions, are there ways in which you see that that could be done better? Ways that we're currently, hey, this is still needing some work, we still need to improve. Or on the flip side, if you feel like everybody's doing it really well, what are some of those specific success stories that you've seen?
I would say I guess it could be a constant struggle, right? Because we put a lot of the tools out there, and maybe some providers or centers are unaware of it. So again, trying to train them and showcase the new tools that we have. And again, we can use dashboards to monitor how many times has the pediatric asthma express link been utilized, and if it's underutilized, trying to showcase and push forward that information again, because our bottom line is trying to make it more efficient for providers to see patients and not, I guess, to not burden them with pajama time and administrative load. So we are constantly looking at dashboards, looking at utilizations of that, looking at information with regards to care gaps and identifying care gaps that at a provider level versus at a center level, how we can best serve and incorporate any health related social needs data to better understand what are the barriers for care for our patients. So I think it's using the real-time data and being able to see if they are in fact using it or not, and maybe if that's not the right way to push that information out, pivot and try to find a different way to offer providers to utilize things.
Yeah, and I think from our perspective, it is definitely a challenge on how do we, really narrow in on this population that, it is hard for parents and for our community to get their kids into the office and to get seen. And so how do we leverage not only our integrated care teams to spread that initiative beyond just the clinician or the provider to the community health worker reaching out and trying to coordinate transportation or trying to coordinate, do you have a school-based health center in your area, and can we go and meet your child at school to do some of that work, so that you're not pulling them out of the entire day. We can see them for a little bit at the school and work through some of that with the provider that is on site there. How are we leveraging a nurse care manager to reach out to you and make sure that we're providing that health education and medication adherence, reviews and things like that. So how are we leveraging beyond technologies and, beyond the provider, our integrated care teams, to really making sure that we are hitting multiple touch points with our patients and with our community to target some of those measures and metrics, and really identify within the pediatric population where those questions are coming from and how we want to, meet those needs with those, pathways and things that Dr. Kaye talked about. So making sure that not only are we alleviating a lot of that burden from the provider, but we're alleviating a lot of that burden for the community and for the parents as well, to make sure that they have the ability to get their pediatric patient seen.
Amazing. And you both already kind of touched on this, but I want to call it out specifically in a question is, how do you make sure that we are reaching the populations who need it most? And what role does data play in that?
Data is everything, I guess we would say, because that real-time data and being able to deep dive into the analytics tools that we have within our Epic instance, we can, again, review those dashboards, see who in fact is utilizing care, who is seeing ER admissions more, who has not refilled their medications. So we can definitely be able to stratify that information, that real-time data, and deep dive into that to know exactly what those identify, what the burdens are for our patients, and what are these barriers, so that way we can best meet them halfway and try to see what we can do to improve their access to care.
Mm-hmm. Yeah, we have implemented a risk algorithm within our population health tool that pulls in different facets of comorbidities through diagnoses, claims, non-medical factors impacting health, things like that, to stratify our patients to alleviate that burden on the health center so that they can easily go in when they're doing pre-visit planning, when they're looking for lists to outreach to for engagement for access, or to close out certain care gaps. They already have that prioritization set for them so that they don't have to dig through the data additionally to try to find those patients. So we try to surface as much as possible for them, to Dr. Kaye's point, to meet them where they're at so that they can just go ahead and identify those individuals quicker, and then leverage like text messaging to the parent to try to get those appointments scheduled, or leveraging portal messaging or email or whatever communication method those individual patients and their families have identified, to be able to get those patients into the office for accessibility.
Great. As we start to kind of come towards the end of today's sessions, I think I have two more questions for you all. The first one being, in a perfect world where there were no barriers, what is something that you all would like to see implemented or integrated, that we're not currently getting to do?
In a perfect world, we'd all be in one system, everybody sharing the wealth of information from health center to health center, so we're not constantly reordering labs or digging through finding out the consult notes and stuff. So and I think we're getting there slowly. Care Everywhere offers that possibility with the health information exchange, that we can see that and avoid costly, unnecessary testing when they already had blood work less than 2 weeks ago at their primary care doctor at the specialist. So I think it's that integration of care, it's that exchange of information, that we would all be in one ideal system, and everybody seeing what the other providers are saying, and we'll see with the future holds of AI and being able to hopefully summarize clinical histories of patients to provide that care for our patients. It's definitely been much of a blessing when I'm seeing patients and I can activate a clinical summary and know exactly what the issues of that patient has been within one-page summary. That allows me to provide better care for my patients.
Yeah, and I would add on to that, very selfishly, from a community health worker care management lens, not only on one platform where we can see not only care that has happened within that health center, but across the state. So bringing in the ADT feeds more comprehensively and being able to see specialist information and things like that. But also integrating community information exchanges. So what other resources were provided to those patients? What other needs may you not be aware of that are impacting their ability to adhere to medical or clinical recommendations? And so how can we all work together across all service lines, dental, behavioral health, medical, even outside of our organizations, to better serve our communities and patients, and just have that all comprehensively in one system. And ideally that doesn't take 17 clicks to find and pull in. And so I think ideally that would really help us serve our communities better.
Well, hopefully we will be able to get there. It sounds great to me. I'm sure everybody on the call is also thinking like, we want that. We take in a lot of information day in and day out. I'm sure a lot of us join many webinars, many virtual training opportunities. So if you're leaving everyone today with just one final thought, one thing you think they should, go forward in the next 6 to 12 months and do, what would that one thing be?
I guess I would say that one thing that would be significant is implementing maybe those outreach workflows and proactive registry, that we can identify patients that are uncontrolled conditions, that are frequent flyers within those ED risk stratifiers, and utilize all that so we can prompt our care teams to intervene early. And honestly, having a future close partnership with Michigan PCA, we can have that strength and support for all participating health centers and provide shared goals around quality, technology, data, and operational improvement. That'd be my goals.
Yeah, absolutely. And I would encourage all the PCAs and HCCNs and CINs to work closely together to ensure that we're all moving towards the same goals and leveraging our resources that we do have and our partnerships across the state to better support our community health centers. And I would encourage the FQHCs and other health centers to reach out to your PCAs and your HCCNs and CINs to ensure that you are taking full advantage of all of the resources and, systems and technologies that they have to offer, because there's probably more than you're currently taking advantage of that could really help you better serve your populations and improve workflows internally for your staff. And so just communicate more, reach out, and really use your HCCNs and your PCAs to the fullest extent.
Together, we're more powerful than one individual health center.
Absolutely.
Absolutely amazing. What a fantastic note to wrap on. Sam, Dr. Kaye, thank you both so much for being with us today. We really appreciate the time and the effort that both you as individuals and your organizations put into, continuing to grow and improve the health center movement. Before we close out for the day, a brief reminder about that final session. Kyranisha is going to put the link to register for that one in the chat, May 28th at 1 p.m. Eastern. So please click that and sign up if you can. And then our last thing is, once again, please fill out our evaluation. It's only about 2 minutes long to get through it, and it really does help us find out what you liked about these sessions and how we can improve them. Thank you all so much for your time today and attending. Thank you to Kyranisha and MHP Salud for co-facilitating, and a final huge thank you to Dr. Kaye and Sam for sharing such concrete, actionable work. We really appreciate everyone being here, and we hope everyone has a great rest of your day. Thanks all.